So, hello. I would like to welcome you all to this recorded session. My name is John Newell-Price. I am the president or the chair of the UK and Ireland Neuroendocrine Tumour Society, and I have been working with AMEND and Neuroendocrine Cancer UK. And the reason why we're having this webinar or this video is to try and give you, the patients, some more information which we hope will help with you managing your condition and just answer some of your queries. And we recognize that this is a very difficult time for patients. You must have your concerns and your worries. And at the same time, the clinicians who have been looking after you and the nurses and the other healthcare professions are also working to try and make sure that your care is as good as it can be under what is incredibly difficult circumstances for everyone in really every healthcare situation. So this isn't limited to the UK, really to anywhere, is really trying to have to work out ways of allowing patients still to be treated as well as they possibly can be with the current public health crisis that we have. So some of the questions that have come in, and they are ones which have been brought together because they are repeated questions which patients have concerns over. And what I'm going to do is first just talk about the types of treatment which people have concerns about that might put them at more risk if they had coronavirus. And that really is a repeated question which very understandably people have concerns about. So I think the first thing to say is that usually your body has an immune system. That immune system is geared up to try and fight things like viruses. Viruses are tiny, tiny particles. And that's part of the reason we can't see them, we can't look at them under the microscope. They're so tiny, and yet they can affect the body. And with this particular virus, it appears to be very good at spreading between people, and therefore all of the normal advice that people have been given about social distancing, about washing your hands, about making sure that if you have a cough, you are absolutely self-isolating. And indeed, you will have seen the government advice about people with vulnerable conditions, and you really need to look at that advice and follow it. And if you have queries, you should liaise with the care team that are looking after you. So usually the body has this fabulous immune system. With this particular virus, it's a virus which the humans haven't really seen before, and therefore it's made all of us more susceptible to picking up the infection. The difficulty for patients is that if you're on treatments that can affect the immune system, that can cause an additional complication or additional problem, because it might make you susceptible to other infections. So, for example, if there aren't enough white blood cells in your bloodstream, it may make you more susceptible to infections either by bacteria, more commonly, and occasionally viruses too. So I think it's worth us just going through some of the treatments that patients who have neuroendocrine cancer or neuroendocrine tumours are on, and then just discuss how that could actually affect or perhaps not affect them. So one of the commonest treatments that people are on are somatostatin analogues. That's either Sandostatin LAR or lanreotide autogel, or indeed octreotide given as an injection yourself, a subcutaneous injection. And the good news here is that we've got no evidence at all that being on those injections causes you any extra risk whatsoever. I think that's very important to stress, because people have had concerns that these injections may cause them difficulty. So whilst the injection itself doesn't cause you any problems, of course the logistics around having the injections are important, because of course some people may have been attending their hospitals to have the injections on a monthly basis. Some patients have it at their GPs, some patients are either self-injecting or having it by home care. So your teams will be contacting you about these things and putting in place ways to try and minimize the need for you to be coming to a hospital, or minimize the need for you to actually avoid social distancing if that is what's being done. The next treatment which people are concerned about is peptide receptor radiotherapy, or Lutathera-therapy. And as far as we're aware, there aren't major risks associated with either having had this treatment or having ongoing treatment. The difficulty is that we haven't been in this situation before, so it's very difficult to give generalized advice. And there is reasons to think that there may be some small increased risk or some increased risk for people who have had such treatment in the months after they've had the treatment. And therefore, the carers who are looking after you, if you are either being planned for or having Lutathera therapy, will be contacting you and having a personalized discussion as whether it is the right thing for you to have that treatment, and a discussion about the various risks versus the benefits of continuing such treatment. It is unlikely that people would be continued on treatment if the benefit to them would be rather marginal, but likewise, if it's clearly a beneficial treatment, then it's a very individualized discussion that will have to be had with the clinicians who are looking after you. And the problem we have is that the Lutathera therapy can reduce the immune system. It can suppress the bone marrow, and therefore there will be potential risk for infections. And that's really where the discussion will happen when people are considering that treatment. Chemotherapy, that's either chemotherapy through a drip or chemotherapy tablets like everolimus or sunitinibs. They certainly carry higher risk. And there is NHS England published guidance about how those therapies should be used. And indeed, that is guidance that applies to all cancer therapies. And if you happen to be a patient who is on such therapy, then your team will be discussing that treatment with you. And in quite a lot of circumstances, that treatment may actually be paused because of the potential risk to you to continuing it. Having said that, again, it's a very individualized discussion, and it may be that in your particular circumstance, it would be appropriate for that to be continued, having had that discussion with your team. Another question people have asked is about diabetes. That's diabetes mellitus or sugar diabetes, and certainly patients with diabetes are at an at-risk group, and they will have been contacted by NHS England, and there is more advice available online. Nutrition is important. If you are a patient who has had treatment and or part of your disease has meant that your overall nutritional status is not as good as it could be, then clearly it would be important to try and be having as much good nutrition as possible. And that's just general advice. Because when there is malnourishment, the immune system is not working as well. So as far as possible, that would be normal food, but some people will either be on or need to consider whether or not they would get extra build-up type drinks from their GP. I think if you've got concerns about that, that is something which you should contact your team about. If you're otherwise well and there's no nutritional problem, then of course you wouldn't need to do that. One of the big things we have to discuss is surgery, and typically for patients about abdominal surgery. And it's a very tough thing, because if you had surgery planned and that has now been cancelled, you're going to be very worried about what the future holds. In the majority of patients with neuroendocrine cancer and neuroendocrine tumours, the speed with which the cancer or the tumours are growing is usually not nearly as fast as some other cancers. And so on that basis, your delayed surgery is less likely to cause a major problem to you compared to perhaps some of the other cancers. And you will have seen some people being interviewed on the television at times expressing their concerns over surgery. It is, of course, a very big issue, but it's again the question of weighing up the risks versus the benefits of surgery. And the problem is, particularly after major abdominal surgery, or indeed any abdominal surgery, there is a problem in suppressing the immune system that makes people more at risk from infections and more at risk of picking up infections. And the other issue is the way we do surgery varies. So, for example, there is a great risk when certain types of surgery are being done to the surgeons and the theatre staff and that type of thing. And therefore, there are some surgeries which simply aren't being done. And for example, laparoscopic surgery is no longer going to be done as any routine. It will be open surgery. But really, these are surgeries that will be done if it's a life-threatening situation. And that isn't to deny people. It's not to try and deny them the treatment they deserve. It's simply trying to weigh up what is a greater risk, either having the surgery or waiting. So you will, I'm afraid, face times when if you had had surgery planned, that will be being put off, but that decision is being very carefully considered and will be conveyed to you again by your teams. And the message is the same. If you have concerns, you need to contact and have that discussion with your teams. So really, the question of all of this is one of the most common treatments that people have is the somatostatin analogues. Increasingly, people are being contacted to see whether or not they'd be able to self-inject or have a partner inject. And if that's possible, that's a very good solution to having this done. But it will be that each of your team will vary. And of course, it depends on whether you've already got home care set up or treatment set up with your GP and how that's going to go forward. Please contact your teams if you've got queries, but actually your teams will be in contact with you and you'll need to be slightly patient with them trying to be in contact with you because, of course, they're trying to contact all the patients they have who are receiving their treatments. Another concern our patients have about what about appointments, what about scans, what about blood tests? So we are having to rapidly change the way that we deliver healthcare. And nearly every single specialty, including all of the clinicians and nurses and other healthcare teams seeing patients with multiple endocrine neoplasia and neuroendocrine cancer, have moved to telephone clinics and or video clinics, in the main telephone clinics. The concerns over scans and blood tests, if there is an urgent need for a scan or an urgent need for a blood test, then that will be done. It'll be done based on clinical grounds, and again, it will weigh up the risk versus the benefit of having either those scans or blood tests done. If you have had scans over the years, and that has shown that by and large your disease has been stable, then it's very likely that your disease will be remaining stable, and therefore your scan may well be being deferred. Of course, that's going to cause you anxiety, and we in the healthcare side of things really recognize that. But nevertheless, the risk to many patients, particularly if they're in a vulnerable group, particularly if they're elderly, is greater by them having a scan than not having a scan in many circumstances. But again, if you've got concerns over the fact that you're not getting scans, then discuss that with your team. By and large, your team will still be in contact with you because most people will still be getting telephone clinics. And at that point, you can discuss your anxiety with the clinicians. It is self-evident that everyone is incredibly busy, and therefore it's just simply not possible to have multiple telephone conversations with multiple people, and it's much better if that is done in a controlled fashion within the clinic. But nevertheless, if you do have a particular concern, then contact your team. One of the other issues is that you may be on surveillance scans. So for example, someone with MEN1 may be having scans, for example, of their pancreas, and often those scans being done every couple of years or so, perhaps every year if an abnormality has been found. And certainly we've been contacted by patients who have had concern because their scans have been delayed, and that's very understandable. But these scans may be delayed for 3 or 4 months. Over that time frame, again, it is likely that the actual issue with delaying the scan will not be very great, and actually it's much more likely that people will come to harm by attending hospital and having the scan, etc., etc. So these scans are being deferred, but again, on a case-by-case basis, if people need scans, particularly if there is a real clinical problem, then they'll be getting them. So overall, what sort of impact is this crisis going to have on you? Well, there are big changes to the service that you have been used to, big changes to the way that we're delivering it. And all of the emergency service and health conditions really are going to have a priority in this circumstance if people are acutely unwell. But that's not to say that your condition is not being attended to. It will be attended to and continue to be attended to in the ways that I've discussed. If you're a particularly high risk, you will have already been contacted directly and you should be taking special measures. If you've got remaining queries about that, I would urge you to look at the advice on the government website, look at the advice on the Neuroendocrine Cancer UK website and amend, which hopefully will give you some further advice. And really, if you have been not contacted directly, then you should follow the social isolation guidelines that are in place for the whole of the UK. Some specific questions that patients with MEN1 have asked us, and one of those is about adrenal insufficiency. So if you happen to be a patient, not necessarily with MEN1, I apologize, patients with any form of multiple endocrine neoplasia, so these are patients who may have had their adrenal glands taken out, so patients either, for example, with von Hippel-Lindau, with MEN2B, perhaps with SDH mutations. If you have had the adrenal glands taken out such that you are taking adrenal replacement therapy, then there is a greater risk if you contact COVID-19 or indeed any other form of infection. You should have received or should know what the sick day rules are in terms of increasing your hydrocortisone at the times that you have a fever. You should have available to you a hydrocortisone emergency pack for an injection if you're unable to take your tablets. But really, the best piece of advice would be to try and avoid contacting the virus at all. And that is to follow the guidance about social distancing. And there is advice on the Society for Endocrinology website, which is freely available to patients, which can give more advice about that. And it documents all of the advice about adrenal insufficiency. There is further advice on the Pituitary Foundation website and on the Addison's Disease Self-Help Group website as well, and indeed on Amend and Neuroendocrine Cancer UK. Another question people have been asking about, well, I'm on a dopamine agonist for my prolactinoma. Does that put me at risk? The good news is no, there's no evidence that should cause you any excess risk at all. One of the other questions was, well, I've got MEN1, I've had a pancreas operation, and because of that, I've now got diabetes mellitus, sugar diabetes. Does that put me at risk? Unfortunately, yes, that puts you at risk in the same way that anyone else who has diabetes, and you should follow the guidance for that. Another question people have got, well, I've got a high calcium level. So patients may have a high calcium level most commonly from overactivity of the parathyroid glands, the tiny little glands that are up in the neck. If you've got a high calcium, there's no evidence to suggest that puts you at any increased risk of the virus itself. However, if you do become unwell and get dehydrated, then the calcium level can rise. So the advice is just to make sure you're well hydrated, not excessively, just to make sure you're well hydrated as far as you can be, just to keep yourself well. Another question is, well, I've had recent surgery. What does that mean? So it depends. If it's been minor surgery, there's no reason to think that that would put you at any other risk. If it's been major surgery, then yes, your immune system could be damped down. That could put you in a vulnerable group, and you should follow the government guidance of patients with a vulnerable group. One of the questions is, should all patients with MEN self-isolate? And the answer to that is no, because very many patients have got a genetic diagnosis of MEN1, MEN2, succinate dehydrogenase, or von Hippel-Lindau disease. And many of them don't have, fortunately, any ongoing issues. If that is you, then really there is no reason to think that you should be more or less susceptible to any problem with the virus compared to anyone else. In contrast, if you're a patient who has got problems going on, either existing cancer or has recently had treatments for that, then yes, as we've discussed already and is available on the various websites, that would put you at risk and you should self-isolate. There's a debate. If you've got a very small amount of disease, so for example, you might be a patient with MEN1 and you might know that you've got a small, for example, 5 to 10 millimeter tumor in the pancreas, and that's the only thing that you have. Under those circumstances, that will be monitored under your usual surveillance program, but there's no reason to think that that by itself would put you at any greater risk. One of the questions, though, from patients who are on the surveillance program is, well, should I delay my annual scans and should I delay my blood work? And the answer to that is yes. In the vast majority of cases, that will be being delayed by your team. But if you get called to have a scan and you have concerns about it, again, contact your team and ask the question as to whether it's really necessary. But in most circumstances, the routine surveillance programs have actually been paused because of that. And indeed, having the routine blood work that you might have done on a yearly basis would have been paused as well. Another question is, well, what do we do about outpatient appointments? Well, the outpatient appointments in many centres at the moment will be continued. You may find that your outpatient appointment may be cancelled, and may be cancelled at very short notice, either because there simply is no one to be able to do that, because some of the healthcare professionals themselves may be either self-isolating or actually sick themselves. And that can be a very dynamic situation and may change very quickly. So unfortunately, you may be called at very short notice to say that your outpatient appointment isn't happening. But where it is happening and where it's happening by telephone, then hopefully you'll be able to discuss your condition and your concerns. One of the questions here is, why would someone with an MEN disorder need to be hospitalized for coronavirus? That would really be based on whether the coronavirus is affecting them in a way that it would affect anyone else. So if there is extreme difficulty with breathing, then if that happens, then one would need to make sure that you contact the usual pathways as illustrated on the government website. But there's nothing different about that apart from the way that it affects people's breathing in the way that you can read up about on the government website. And then there's a real question about what are the potential complications of MEN and how could that affect their recovery. And people have been concerned about patients with adrenal insufficiency. So for sure, if you have adrenal insufficiency, if you contract the virus or any other infection whilst you have a fever, you will need to increase your hydrocortisone or your prednisolone or your dexamethasone, whichever steroid tablet you're on, whilst you have the fever. It's important to emphasize the vast majority of patients who contract COVID-19 or coronavirus are going to get a mild infection. Under that circumstance, you need to take extra hydrocortisone whilst you have it and then reduce down to your normal dose afterwards. If you become more unwell, then you will need higher doses of hydrocortisone. So there is no reason why you shouldn't even triple your dose if you're becoming more unwell. It can never do you harm, but you would need to seek medical advice. And if someone becomes more unwell that and requires hospitalization, then it's very likely at that stage you're going to be being given higher doses of hydrocortisone, and indeed hydrocortisone via drip or injections as necessary. In terms of recovery, once over the infection, it's a case of the dose being gradually reduced back down again, and then going back to the original dose of hydrocortisone or other steroids that people are taking. Patients with diabetes need to monitor their diabetes very carefully if they become unwell. And again, if they're finding difficulties, they need to contact their diabetes nurse. But in terms of the recovery, it'll be a question of the dose may have to be adjusted. Sometimes the dose needs to be increased, while sometimes someone's acutely unwell and then decreased afterwards. But that, again, is very individualized and will vary between patients. And really, finally, there was a final question about, well, how will I be affected in terms of if I've actually got MEN1, and unfortunately I have, for example, metastatic disease in the liver or ongoing cancer. Again, the patients in that circumstance, in terms of recovery, most patients will still be getting a very mild disease and should be okay in the main. If people pick up coronavirus and it becomes worse for them in terms of their recovery, and they need hospitalization, then they will be spoken to and being given advice by the physicians looking after them when they're there. So I hope that answers at least some of the questions that you have got or have had. We've hopefully aimed to try and do that. And really the answers to those questions will largely also be available on the Neuroendocrine Cancer website and also on the MN website. You've also got resources on the government website. And with that, I wish you all the best. It's a very difficult time for you. I wish you all well. I hope you stay safe. And I'm going to finish there. And thank you for your attention. Bye-bye.